Now let's move over into, or actually up into the renal system and talk about kidney stuff. The most important thing you need to know when you're dealing with the renal system is the labs. And I've drilled this into you guys. The most important labs in your renal system are your BUN and your creatinine, blood urea nitrogen, and your creatinine. Both urea nitrogen and creatinine are excreted by the kidneys. So you have some in the bloodstream, but most of it should get excreted by the kidneys through the urine. So you should have anywhere between 8 and 20 units of urea nitrogen in the bloodstream. And you should have between 0.4 and 1.6. Those labs will change a little bit. This one gets a little bit lower. Sometimes you'll see some labs as low as 1.3, 1.4. For this, your creatinine is actually a much more specific marker for the renal system. But those are the two you absolutely have to know. When these two start getting higher in the bloodstream, they're not getting excreted in the urine, and your kidneys aren't working. Classic symptom that your kidneys are starting to fail when your BUN and creatinine start rising. And when they start rising, then they can lead to increase in nitrogenous waste in the blood. So the whole point of the kidneys is to remove excess stuff that your body doesn't need. So you ingest food and you're getting all the nutrients, and your body is using those nutrients and getting rid of the stuff that it doesn't need. Dumps it back into the bloodstream. It goes through your kidneys, and I'm going to show you that in a second. And then you can, then it gets excreted if your kidneys are working. So let's talk a little bit about your kidney. This is a nephron. This is the functioning unit, the thing you need most with your kidneys. And so this whole nephron, this whole section right here is the nephron. Now, right in here is Bowman's capsule, and inside the Bowman's capsule, this is the primary filtering device. So the arteries coming out of the left side of the heart, the left ventricle is pumping blood to the kidneys. The kidneys get a ton of blood. I think it's about, I don't want to tell you wrong, I think it's about 20% of every cardiac output is going right to these kidneys. And so what's happening is it's coming down in here to the Bowman's capsules and figuring out what's there, and it gets rid of stuff, you know, that it doesn't need or that it doesn't want, and it'll take out like it will take out the urea, takes out nitrogen, you know, things, all the stuff that is normally found in urine. It identifies it and it starts taking it out. Sodium, water, and it's down in here where the kidneys can figure out if a person is dehydrated, then the kidneys will start holding on to water. If the person has hypervolemia, too much fluid, it's going to pull a lot of that water out. And they can tell if the blood pressure is high, the blood pressure is low, and they will adjust, the kidneys will adjust water and sodium retention based on the patient's blood pressure. So that's where this is occurring. And the other thing I wanted to point out here in your nephron is this is the convoluted tubule where some of the diuretics work, but down in here, if you remember, this is the loop of Henle, and a lot of your diuretics like Lasix works in the loop of Henle. Now the reason this is important is because you see how it goes down through the arterial side and then comes back up through the venous side, so lots of filtration is occurring in here. And your diuretics, like the Lasix, works down in here, and it will tell this loop of Henle pull out more fluid. So that's exactly where this works. So that's what that is. You probably remember that. Hopefully you remember that from physiology and patho, but there it is. Just so you know what the heck we're talking about. So this is what I wanted to tell you about when I was talking earlier about how to identify some of your renal disorders. So how do you know somebody has a renal problem or a kidney problem? You've got to do your diagnostics. Your serology, this is blood work. Serum, that means blood. So if you see that word, it means blood work, and that's the blood urea nitrogen and the creatinine that I was telling you about. Another classic way to figure out if your beans aren't working is in your urinalysis. Your kidneys should be retaining all sugar and all protein. We get rid of that in different ways, but your urine should not be spilling protein and it should not be spilling sugar. If you have protein and sugar in your urine, your kidneys are starting to fail, and that's a classic sign. Cystoscopy, this is what a cystoscopy looks like. So the healthcare provider will just put a scope right through the urethra and up into the bladder, and that will give you a picture like I showed you with the bladder cancer. That's a cystoscopy. Pretty simple. These patients, they don't have to, it's not like a colonoscopy where they have to, you know, you've got to like drain your colon for 24 hours. You can pretty much just empty your bladder and then have a cystoscopy. An IVP, this is really common in renal patients. It's called an intravenous pyelogram, and what happens is the patient will get an IV, and they will put contrast dye in the IV, and then under radiography, they can see where these are the kidneys up here. This is the renal pelvis up here. These are the ureters that come down here and down into the bladder, and you see how all that contrast shows up. So when your patient is going for a contrast scan, this is what they're looking at. If they didn't have contrast in, you would not be able to see these. So you can see here that there might be a little problem right here. See how this left ureter is supposed to come down like this? And it looks like there could be a little bit of problem there, but the bladder is, you know, nice and full. So that's an IVP, an intravenous pyelogram. Another thing that they do a lot in your patients who have kidney problems is to do a retrograde pyelogram. Now, a retrograde pyelogram is very similar to an intravenous pyelogram, except as the name shows, intravenous is going to be through your veins. A retrograde, now this one, they're going to put a catheter through the urethra into the bladder, and then they will thread it up through the ureter. And see in this radiograph, see how they're just going up through the guy's right ureter? So they inject or put this catheter in, and then from there they start injecting the dye, and see how it's going up backwards from here. That's a retrograde. It's going backwards up through the ureter and then up into the kidney. So that's another way to look at the kidney under radiograph. And the reason they might do that is if the patient has an allergy to dye, you know, like the shellfish allergy. These are the people who are going to ask if they're allergic to shellfish because the dye is made out of that same kind of stuff. Lobster, crab, shrimp, that sort of thing. And also because some of the dye is nephrotoxic. Dye can be hard on kidneys. It can be hard to get rid of in kidneys. So if you're already worried that somebody has a kidney problem, you might have to be a little more cautious and not give them a nephrotoxic agent. If none of those work, then you can always get a CT scan. This is a CT scan of the beans. Here's the spine. This is the liver, stomach over here, and your kidneys are sitting up there. And you can notice that right here and right here, we got some hot spots. See how it's showing up white, and you don't have this over here in this kidney. So this could be like a kidney stone, but it's huge. You know, this would be like a calculus stone up in the horns of the kidney. And then finally a CT scan. This is what a CT scan looks like. And again, the CT scan, unlike the MRI is a lateral picture like this. A CT scan is cutting across, you know, medial like this. So here's the beans right here, little kidneys, looking good. This is the spine. These are just loops of bowel in here. And see, sometimes the bowel has stuff in it, sometimes it's got air in it. So spine back here. This person's actually a little bit obese. See all this? This is all adipose tissue. Okay. So that's a little bit about diagnostic kidney stuff. Now we're going to talk about specific kidney disorders. The first thing I want to talk about is nephrolithiasis. Lithiasis is the word stone. Nephro is kidney. You can have stones anywhere in the renal urological system. So you can have kidney stones, you can have stones stuck in the ureters, you can have stones that go all the way down to the bladder. But most of them are kidney stones. Not super uncommon. A lot of people have kidney stones. So the signs and symptoms is it's very painful, excruciatingly painful. Some people have equated it to childbirth. I don't know. I've had children and that was not pleasant. So I don't know if it's just, I don't know. But everybody says that it hurts. So one thing that you have to do as a nurse is treat pain. You've got to get this person out of pain, because what's happening is there is a stone that gets stuck up in, that gets formed in the kidneys, and then it starts passing down through those little ureters. Well, those ureters are little tiny things, and those stones tend to scrape along in there, and it hurts really bad. So patients will complain of like flank pain, they might have nausea and vomiting, and they can be very, very sick. You need to be very careful that that's not getting infected. You want to identify it early. Patients can have fevers, elevated white blood cell counts. They can be like start vomiting and not wanting to eat, so they're getting dehydrated. So you have to identify it kind of quickly. And some ways that you do that, because those symptoms are kind of vague and a lot of things sort of mimic that, get a good diet history. And I'm going to tell you a little bit about the diet in a second. There's a couple kinds of diets that put patients at a higher risk for kidney stones. If somebody's had a kidney stone once, they're more likely to get it again. So you really need to be careful with some nutrition education and nutrition identification, so that the stones, they're not at higher risk for getting a stone. Sometimes it can run in families. There is one genetic component that they have identified. It's called cystinuria. And that is a genetic component that makes put somebody at a higher risk for developing stones. And certain medications can contribute to the development of stones. So you want to get a good history on your patient, get a good medication history and a good diet history. This is what the stones look like. This obviously is the kidney that's opened up, and you can see these stones that are in the like. This is like the like calculus of the kidney, and these stones are here, and they're going to get ready to come down the ureter. Obviously they've had to take this kidney out. This is what it looks like when it's coming down the ureter, and so this, they've got a scope up in there, and you can see this thing is just jammed in there. Well, the problem with this being jammed in there is now all the urine and stuff is going that the kidney's trying to get rid of is going to back up, and this can cause some kidney infections. So there's a couple different ways that we can treat it. One is called lithotripsy. This is a picture of a lithotripsy, and what they do in lithotripsy would be like in here, where they can actually visualize the stone. They would go up into the stone and put a like a shock wave treatment on it. Litho, again, being stone, tripsy is breaking it up, and so they put this vibrating shockwave thing on there. What it does is that it starts breaking the stone up into little pieces like sand, and then hopefully then the stuff will, the pieces of stone then will be able to be excreted. Now, you do need to be careful in your patient who's had stones with lithotripsy, is you want to make absolutely sure that that person is getting rid of all those pieces. So you're going to hydrate them very well. You want to flush those kidneys, so you're just keeping that those stones flushed, because if it gets stuck in there, the patient's at high risk for an infection. There's some other ways to treat kidney stones as well. If it's too big, the patient might have to go in and have surgery. So some of those stones, like in that other picture I showed you, are just too large, or they're stuck up in the horns of the kidney, like that. I think it was the MRI that I showed you, that's a pretty humongous stone up there. There's no way that's going to come out. So sometimes they have to have surgery. Another thing that they can do besides internal lithotripsy is an extracorporeal shockwave therapy. And they do that just percutaneous. It's right through the skin or on top of the skin, and they do shockwave therapy, and then the same thing happens. So the patient might be a little bit bruised there in the spot, and they might have a little bit of bleeding in the urine and some sediment in the urine. They shouldn't have bright red bleeding. Anytime you hear that your patient, or you see that your patient's having bright red bleeding, that's not good. Notify the healthcare provider, because they've got bright red bleeding and something's wrong. I would show you a picture of that, but this conversation is going to go too long. So if you want to, just look up on YouTube extracorporeal shockwave therapy. The next thing that you need to do when you're assessing somebody for kidney stones is to figure out what it's made out of. So usually once we've identified that somebody has a kidney stone, we give them a little screen and a cup to pee in, and we have them pee in this cup with a screen in it until pieces of the stone come out. And the reason is we need to analyze the stone. We need to figure out what's going on, because we treat it different. So once we've done the lithotripsy, it is really important to monitor urine output. You've got to make sure that that patient's at least 30 mLs an hour, and typically more is better in these patients. Like I already said, the patient could have a little bit of pain or tenderness where they had to go in and do the lithotripsy or the extracorporeal shockwave therapy. We want to really increase fluids. This is different because historically in our patients who had nephrolithiasis, the thinking was to not have them drink because we thought they would get fluid overloaded. Well, that's not the case. So we want them to drink, we want them to flush this stuff out. And diet is really, really important after lithotripsy. So you need to understand nutrition. This is where teaching is so very important. So now here's the problem. And actually, let me show you this next slide. This is what's going on. Your stones can either be a purine or uric acid stone, an oxalate kind of stone, or a calcium stone. So those are the three main kinds of stone that a patient can develop. Now, usually once we identify that stone, we send it to the lab, then we can tell the patient what they should avoid eating. So if your patient has a purine or uric acid stone, these components are heavily found in organ meats. Not that anybody would eat that, like liver and kidneys. Like, I don't know who eats that, but they should be eating it anyways. Bony fish like sardines, shellfish, anchovies, asparagus, and mushrooms are very high in purine. So if it's identified that the stone has a purine component, they can't have these foods, or they shouldn't eat these foods. Oxalate stones, a lot of people eat these. These are very common. It's found in chocolate, green leafy vegetables, tomatoes. So the problem here is that, especially like with your green leafy foods and stuff like that, those are also very high in some nutrients that we want our patients to have, vitamin K and stuff like that. So you do need to make sure that they're getting those other nutrients in other places of their diet. These patients should also restrict their protein in their diet a little bit. Now, here's the problem. Most stones are calcium-based stones. Calcium, as you know, is found in dairy products. And a ton of food have calcium in them. Milk, cheese, yogurts, yeah, and wonderful things that we need, to prevent osteoporosis, keep maintaining strong bones, lots of vitamin D. However, what they have found, and we used to in the old days, would also restrict calcium in the patients who had calcium stones. But what we found now is that if they limited their calcium, then they started having bone loss. And so it was a bit of a catch-22. So now if patients have a calcium stone, we actually still let them eat calcium. So that's the only one. If they have calcium, you can still, we don't limit that calcium intake just because it's so devastating on the bones. So in that case, you do other things like making sure the patient's very well hydrated, that they're able to identify signs and symptoms very early. You know, you don't want to let them get dehydrated or, you know, things like that that would kind of lead to that sort of stone. So this is the only one that's a little bit different. These two, you've got to alter their nutrition. So that is nephrolithiasis, stones in the renal system. The next thing I want you to be aware of is that a lot of things can damage the kidneys. And we have a ton of nephrotoxic drugs that we give our patients. Many of the antibiotics can be nephrotoxic, especially what we call the big guns, like the aminoglycosides, like the gentamicins, the tobramycins. These are some of our big guns. They're great for hard to control bacteria, but they're really hard on the kidneys. Other kinds of drugs like chemotherapy drugs, some of your non-steroidal anti-inflammatories, your Motrins, Advil, any of your NSAIDs, those can be really hard on the kidneys. Some of your penicillin antibiotics, especially if somebody is on, like, let's say you put them on a penicillin and they're also taking NSAIDs or they're also getting like a chemotherapy or something like that, that combination can be very hard on drugs, can be nephrotoxic. As well as some of the dyes, like I told you about, like the radio contrast dyes, that can be really hard on the kidneys. And so you need to be, one, aware of what you're giving your patient. Two, how do you know that that's affecting the kidneys? Well, you start doing some of those diagnostic things I just showed you. Check their blood, check their BUN and their creatinine. And the other problem is if the patient starts having an alteration in their urine output will typically decrease when the kidneys are starting to stress and the kidneys are starting to get damaged. That urine output will start dropping. Well, what happens when you have a decreased urinary output is that the risk for cardiac arrhythmias can increase because the potassium can increase. So when you're not excreting urine, you're not getting rid of, you know, the potassium like you should, it starts to build up in the bloodstream and it gets greater than 5.0. Remember, normal potassium is 3.5 to 5, gets higher than that, now your patient's at risk for cardiac arrhythmias, which is why it's so important to be very astute in managing your patients who are getting some of these nephrotoxic drugs. So once the kidney starts to get damaged, it can lead to something called glomerular nephritis. And remember the Bowman's capsule, the glomeruli, that big structure I showed you in the beginning with the convoluted tubules and loops of Henle. That whole thing is the glomeruli. That's the powerhouse center for the kidneys. Glomerular is that area that I just told you about, the powerhouse of the kidneys. Nephritis or itis is an infection. So this is just a common a broad term for injured glomeruli, and a bunch of different things can injure the glomeruli. You might hear it called nephritis, nephrotoxic syndrome. All of those things mean the same thing. And basically what's happening now is because you've damaged that tubule or the glomeruli, now the kidney, which is supposed to be getting rid of all this waste product, can't. So then what happens is all those wastes, all the extra fluid, all the electrolytes that are supposed to be excreted in the urine, they're not. So where do they go? They hang on the bloodstream. Well, when things start hanging out in the bloodstream, the rest of the body doesn't like it. So now instead of nice healthy blood floating around, now you've got a bunch of uremia, uric acid, too high of potassium, fluid overload, and all the other organs start swimming in that, and they're not happy. So what happens then is that those glomeruli start dying, and that leads to kidney failure. It's a general term for kidney failure, and then we've got two types of kidney failure: acute kidney failure and chronic kidney failure. So I'm going to tell you a little bit about both of those, and then I'll probably stop the video again just so this doesn't get too terribly long. So in an acute development of glomerular nephritis, acute is that word that means that it comes on very quickly, very rapidly, and it can be caused by a variety of different things. Oftentimes patients who have been sick before or have had an infection somewhere else, then for some reason the kidneys don't